organizers for giving me this opportunity to present this case. I will be presenting a bilateral T.K.R. which was done in stages in a known case of a rheumatoid arthritis. So the history was, she is a 54 years of a obese female and she is having pain in both the knees. Left is more bad than the right. And there is a difficulty in walking since last 10 years. And now she was confined for her daily routine activities. She needed assistance. Her BMI was 32. And as I told, she is a known case of RA. And on DMARDs since last 10 years, regularly taking methotrexate. And before the surgery also, she was on methotrexate, hydroxychloroquine, sulfasalazine, and intermittently on the steroids. That was the physical examination. On the right side, the varus was around 10 to 12 degrees, left side 20. Medial joint line tenderness present on both the sides, varus thus gauged, and there was a FFD of 10 degrees on the right side and left on 7 to 8 degrees. These are the deformities and the gait. She needed assistance for even walking also and from getting up from the bed.
So I think here you stop, Nilay. Yes. I think I'll have an opinion from Sushrut. Sushrut, how will you proceed for this one?
Sir, definitely she is a candidate for a knee replacement. But before that, we need to see what all medications are going on for the rheumatoid arthritis. We need to consult with a rheumatologist to prepare her well. We need to stop some immunomodulators if it is there, or methotrexate, and then should we go ahead with the knee replacement.
How will you proceed for the surgical part? Now this is the medical management. Yeah. How will you proceed for the surgery?
I'll do a staged knee replacement.
Okay.
Definitely not a candidate for bilateral in my hands.
Yes.
Because of the severe varus deformity, and I'm a proponent of mechanical, obviously she'll require the medial and posterior medial releases. And a routine, I think a primary knee replacement should suffice.
Come to the pre-op X-rays, please.
Yeah.
X-rays. Yeah, thank you.
Yeah. So on the right side, I think we can definitely get away even without the graft. But on the left, maybe bone graft or alternately a CC screws may be required.
I think Yadav sir, bilateral now, you have to take a final call. Yadav sir, please. In spite of rheumatoid, immunocompromised. Okay. Sir, on the mic, please. Sir, on the mic, please.
Bilateral.
Okay. Dr. Nakul, how would you approach?
Provided she is medically fit and the bone stock is reasonably good, I would keep a stem on the left side especially, and will proceed with a single stitch bilateral.
Okay. Other panelists would like to have any different opinion?
No, same. I will do single stage bilateral.
Okay, sir, please.
I'll do stage left side first.
Sir, any reason for, like, they have a opinion of doing bilateral simultaneously, you have staged?
Yeah, I don't like doing bilateral simultaneously. That is basically that's because of my problem. I got knee arthritis, so I can't stand for 2.5 hours.
So, Jurani sir, please.
Yeah, so simultaneous bilateral, she is a young patient and I'm sure the cardiopulmonary reserve would be good in spite of her being a RA patient. Now that's answering the question for bilateral, simultaneous.
Yeah.
Now when you look at the x-rays carefully, when you remove all those osteophytes, there are big ones medial on the tibia and the femur. So you will be able to correct this deformity quite easily. I don't think correction of deformity is a big challenge here. I would disagree that I would not like to use a stem in young patients at least, but I'd like to take a 2 millimeter more cut of tibia and maybe use a 11 poly. But I would like to get rid of the defect and avoid a stem in a young patient.
Okay, thank you. Anil, please, your final opinion.
In my hands, staged.
Okay. Okay. So,
We consulted the rheumatologist. We stopped her all drugs.
Yeah.
And there was controversy regarding continuing with the methotrexate.
Okay.
whether to continue or not to continue, because her titers were very high, from 50 to 250.
We will come to the surgical
We did her
part. We are short of time.
Fine.
Yeah.
We did her titers pre-op. Those were well within limit. CRP was well within limit. Her RA titers were below 20, and we planned for a conventional T.K.R. with Zimmer Next Gen. I kept ready 4 mm CC screw and planned for a graft also. And I kept ready the stem on the tibial side. We did the left knee first, and I checked thrice for the condition of her skin condition, which looked very good that time. And since the bones are porotic and she is known case of RA since ages, the chances that the disease will continue and she will continue to have porosis. These were her intra-op findings. There was a posterior medial bone loss. I fixed it with a screw and a bone graft. I'll skip the images. That's what we did.
Okay. So,
But the problem started when on the third post-op day only, the wound was looking like this. And on the 15th post-op day, there was erythema in the distally, just above the tibial tuberosity. And this went into non-healing. So during all the post-op course, there was no fever, and not a single time pus was drained, or there was no draining sinus. So I was surprised to see whether it is inflammatory or it is because of non-healing property that she has gained from the chronic use of the anti-rheumatoid drugs and the steroids. So I put her on the VAC. VAC was kept there, and after removal of a VAC, I sutured the wound. Before suturing the wound, I pressed the wound to see whether some pus or some drainage is coming from there. The plan came to my mind of aspirating her joint, but since the joint looked quiescent and the patellar tap test was negative, I left that thought and haven't aspirated the joint.
okay.
So
So, hold on, Nilay.
Yeah.
So, from the panelists, any would like to intervene at this particular time? The wound looking erythematous, VAC being applied, any difference?
So congratulations for presenting this very important point of non-healing in rheumatoid patients. So skin in rheumatoid patients can behave like this.
Yes, sir.
But this is not deep infection. This is not PJI. So this is just delayed healing. So you did the right thing by applying back.
Okay.
And I'm sure it would have healed.
I think the point is in rheumatoids, vascularity is a big problem. So in the lower third of incision, if you use a lot of cautery, then such things happen. So message for the next time is use less cautery in rheumatoid in the lower third of the incision.
yeah, it was nightmare seeing this patient. The
Okay.
wound is not healing because the chances of secondary infections were very high. These are what I will skip
Okay.
this.
Yeah.
Then after the wound on the left side healed, then I planned for the right knee, and it was quite straightforward. And these are the post-op pictures of both the knee, and that is the, just a minute, that is the current status.
Yeah. So, nice case, Nilay. What medicines, like what anti-rheumatoid you started after the wound healed, or how much did you wait?
We started her on methotrexate again after 20 days of second surgery, after the suture removal of second surgery. Till that time, she was on hydroxychloroquine only. And that is around 8 months post-op that she is working.
I think the current concept is not to stop any medicines for rheumatoid. It has no meaning whatsoever. It's all in mind. Nothing happens to that. And secondly, if they are having a good hemoglobin, everything, all this skin is because of retraction many times. I think they are very flimsy skin. Too much of retraction is really bad. So drugs has nothing to do with any of these things. It can be continued till surgery, during surgery, after surgery.
Sir, but what about steroids, sir?
Yeah, I agree with you.
It is
In-
must.
in
Steroids
AIDS-
are must. You should give steroids to this patient because they will give us good, if they have a cortical suppression sometimes.
They say
So
that-
they can be given steroids, nothing wrong with steroids. It doesn't cause any increase in infection. Yeah, but no,
On
steroid
mic,
doesn't-
on mic.
Actually, we give steroid 2 doses all patients post-op, isn't it?
Yeah.
So, sir, I
भाई
would have
mic
probably
बोलना यार।
erred towards opening that
इधर से
wound
बोलो, वहाँ पे
superficially
बैठे मत बोलो।
whatsoever, give a wash and probably close it probably
Mic
rather
लो,
than
mic.
going in for a
Mic लो, बोलो,
superficial
बोलो।
vac.
कहाँ पे mic है देखो?
It's always better to open up, wash, and we cannot take a chance with an infection. We don't
Yes,
know.
sir.
Not every infection will throw pus on day one.
My question to panel is, which disease modifying anti-rheumatoid drug will you stop, and what about steroids? Will you continue or will you stop?
Pathare sir wants to
Yeah,
comment on something.
I'll tell you, recent data of you can continue all the drugs. Only biological drug should be stopped one cycle, and that's it. Steroids should be given, and during intraoperative also you might give a little loading because their adrenals are not working.
I think one of the most important parts of RA is vasculitis. Inflammation of vessels and microvasculature being affected. I think one of the most important parts which we keep forgetting while handling rheumatoid tissues, especially skin. That needs to be
Secondly,
kept into mind.
the stem used, if you use a stem, there's no need of putting those screws. It is such a long stem, the screws could have been avoided actually. There's no need for screws.
With such a bad looking wound, would it be pertinent to do a aspiration and do some kind of investigation, or just wait for day 12 or day 14?
I did investigations. I did CRP, ASR, and routine CBC counts,
So
which
wasn't
were well within limits.
But
And
CRP was normal.
yeah,
CRP was normal.
CRP was normal.
but in rheumatoid you get high CRP than ESR.
I think immediate post-op aspirations, lot of time.
In
just show
rheumatoid,
pustils.
CRP and ESR don't hold much.
Yeah,
value.
because they are already on a higher level. Yeah.
So,
So thank you, Nilay. Thank you so much for this case.
so
Yeah.
I would like to invite